Okay, so I think we'll get going so that we can keep to schedule. I see we are currently at 90 and counting people online. Fantastic to see. So welcome everybody. This is the 2021 Tine Haworth Cardiovascular Research Day. It's really fantastic to see everybody here online. I want to welcome you to this very important research day hosted by the Libin Institute. And I just want to really take a moment as we kind of get the program started here. I just want to take a moment to acknowledge everybody for their hard work over the last year and a bit. Clearly, we're still dealing with the COVID-19 issues, and this has had some impacts to varying degrees on different people, of course, and their ability to conduct research. But I know that the majority of people have really gone to great effort to pivot and to be nimble and flexible in order to keep their research activities going. And I really want to acknowledge everybody. So that includes graduate students, postdoctoral fellows, technicians, PIs, undergraduate students, medical students, everybody involved in research. Just want to really acknowledge you for your hard work over this last year and a bit during the COVID-19 pandemic. To me, the pandemic has demonstrated that research has never been more important, all research. And so I congratulate everybody that's continued to put their efforts into their own work and in order to continue to make their research happen. And this day, of course, happens every year, and the purpose of the day is to celebrate our research accomplishments. And normally we would like to meet in person, and we're still not able to do that. But it's fantastic to see so many people have signed up and are here and are participating online. Of course, if we all get ourselves vaccinated and are careful, hopefully we will be returning to some kind of normal in the foreseeable future, and we'll look forward to this event being back to an in-person event next time we run it. So I also want to take a moment to acknowledge Dr. Jennifer Thompson and Megan Smith in the in the Libin office, and a number of other people in the Libin office as well. Jennifer and the team really are the ones that have organized this event. So congratulations, Jennifer, and thank you for your hard work to bring this event together. Jennifer was going to have some further comments for us in a few minutes. Megan, maybe if we can go to the next slide. Let's just take a moment, if we could, to acknowledge the traditional territories of the people of Treaty 7 region in southern Alberta. This includes the Blackfoot Confederacy, which is comprised of the Siksika, the Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, which includes the Chiniki, Bearspaw, and Wesley First Nations. City of Calgary is also home to the Métis Nation of Alberta Region 3. So with that, again, welcome everybody. Thank you again for being here. And Jennifer, I'll hand it over to you now.
Okay, thanks, Rob. Hello, everyone, and welcome to our annual research day. I'm going to start by saying a few words about Tine Haworth. She is the namesake of our annual research day and the Tine Haworth Scholarship in Cardiovascular Research. Her passion for education and cardiovascular health prompted her to donate more than 3.7 million to the Libin Cardiovascular Institute. And it is this donation that made this day possible. So we are grateful to Tine Haworth. Next slide, Megan, please. Okay, so before we start, I'm just going to provide you with a few housekeeping reminders. The sessions will be recorded. Judges, moderators, and speakers, please turn on your cameras. Participants, you can also consider turning on your cameras as this helps the speakers connect to their audience. Please remain muted unless you are speaking. During the Q&A sessions, use the Zoom raise hand function in order to ask a question. We can also use the chat box. The moderators will be watching the chat box, but because the Q&A opportunities are so short, it'll be a lot easier if you use your raise hand and your audio to ask a question. For the TED style talks, there will be no Q&A period. Presenters, you will be responsible for sharing your screen. However, the moderator does have a copy of your presentation just in case there are technical difficulties. Also, speakers, the moderators will be cueing you when your time is coming to an end. Okay, so they will be using the thumbs up button. The first thumbs up will indicate that you have 1 minute left of your presentation, and the second thumbs up will indicate that your presentation needs to end. The moderators will be responsible for facilitating the Q&A sessions. If anybody has any questions throughout the day, please don't hesitate to contact Megan Smith. You can see her email on this slide, and you can also find it on our website. Okay, so on the Libin website, you will find the full agenda. You will also find all of the links to the Zoom rooms, and you will find the presenter order. For those who have ordered a lunch provided by Fork and Farm Catering, the deliveries have begun, and you'll receive your lunch by 12 p.m. Please ensure that you are available to answer your phones to be notified when your delivery has arrived. If you live in an apartment building, you must go to the front door of the building to receive the delivery. So I will now pass it on to Ali Hassanabad, who will give a short announcement. Ali.
Hi, good morning, everyone. Thanks to the organizers, Dr. Rose, Dr. Thompson, the entire Libin community. I'm just representing CIP as well, the Clinician Investigator Program, as the chief resident of the program. Wanted to put a plug for our program here in Calgary. It's open to residents who are pursuing formal graduate training at the U of C. It's a great opportunity to get involved with research and have Royal College funding, and also at the end to have accreditation from Royal College. There is a fantastic website that we have worked on over the past couple of years. I recommend you guys check it out. The point of person to reach out to if you have any questions or concerns, you can either ask myself or Stacey Anderson, and we'd be more than happy to answer any questions. But please do, thank you, Dr. Fedak, for bringing up the link. But please do share this with your trainees within the different institutes that you're part of. It's a fantastic opportunity for all trainees. Thank you.
Thanks, Ali. Next slide. Okay, so we are going to kick it off with our scientific talks. Dr. Sarah Childs will be the moderator of this session. She is an associate member of the Libin Institute and department head of biochemistry and molecular biology. Sarah, you can take it over.
Actually, I'm a full member. There you go.
Oh, sorry.
Welcome, everyone. So this is the first session. As Jennifer just outlined, these are short talks. So there's 8 minutes for the talk and 2 minutes for questions. But actually, there's a buffer of time in case technology goes awry. So we actually might have more time for questions if the technology works. So let's just hope it works all day. So get your questions ready. As you've heard, you can either put your questions in the chat or the raise hand function, and I'll try and monitor both and make sure that we get those. So definitely, let's make it a lively day. So our first speaker is Elaine Soriano, and she's going to talk about long-term neuroprosthetic hemotherapy prevents blood pressure instability after spinal cord injury. So Jen, can you please share your screen? Perfect. Oh, Jen, I'm going to do the thumbs up after 7 minutes. So you still have 1 minute left, okay?
Okay, perfect. Can everyone hear me? Okay, my name is Elaine Soriano, and I will be talking about long-term neuroprosthetic chemotherapy that treats autonomic dysflexia after spinal cord injury. So this is a CT scan of a patient with spinal cord injury who suffered from hemorrhagic stroke. Autonomic dysflexia, or AD, is a secondary consequence of high-level spinal cord injury. AD is a rapid and severe increase in blood pressure that can lead up to 300 millimeters per mercury, which causes repeated insults to the heart and the blood vessels. And this can lead to heart disease and stroke, as I have shown here. But how does autonomic dysflexia develop? First, I wanted to start by saying how I'm interested in studying the autonomic dysfunction following spinal cord injury because of how much we learn about the integration between the cardiovascular system and the nervous system. So following spinal cord injury, there is an interruption between the circuits above and below the lesion. Specifically, the descending inhibitory commands from the supraspinal structures are interrupted. So this can lead to aberrant hyperexcitable sympathetic circuits. Basically, simple daily experiences such as bowel distension can lead to hyperexcitable circuits below the lesion. And this can, and these circuits extend abnormally to the sympathetic neurons, controlling blood pressure, leading to vasoconstriction and increased blood pressure, which we term autonomic dysflexia or AD. Previous study also showed the specific neuronal subtype that are overactive during autonomic dysflexia. To mimic bowel compaction or bowel distension, colorectal distension or CRD was used in this paper to induce autonomic dysflexia. So this paper showed that high colocalization of CFOS, a neuronal activity marker, with excitatory or VGLUT2 positive interneurons. So from our previously published work, we showed a specific region in the spinal cord that houses the circuitry involved in blood pressure control. We termed this region the hemodynamic hotspot. Furthermore, previous clinical studies have shown that long-term targeted epidural stimulation can shift the hyperexcitable circuits to its normal phase. Therefore, we hypothesized that chronic epidural stimulation will prevent these aberrant hyperexcitable sympathetic connectome and reduce autonomic dysflexia. For one of our experiments, first we implanted a wireless chronic telemeter device to monitor blood pressure and renal nerve sympathetic activity. And we have 3 groups specifically for this experiment. Namely, we have the uninjured, injured, and the neurorehabilitation group. So as you can see here, we have the sensor into the aorta sensing blood pressure. We also have electrodes monitoring renal nerve sympathetic activity. Next, for the injured and the neurorehabilitation groups, we performed a T3 level spinal cord contusion to mimic a complete spinal cord injury. This image is a reconstructed image that shows the interrupted projections from the rostroventrolateral medulla due to the lesion caused by the T3 contusion. For the neurorehabilitation group, we implanted the epidural stimulation array specifically targeting the hemodynamic hotspots, namely T11, T12, T13. And we performed a daily epidural stimulation for 30 minutes for 7 weeks. Again, one of the most clinical causes of AD is due to bowel compaction. To mimic that, we use colorectal distension to assess the severity of AD using a balloon-tipped catheter inflated in the colon. The functional assessments were performed once a week for 7 weeks. For 3 groups, light gray for uninjured, gray for injured, and red for neurorehabilitation. For both injured and neurorehabilitation groups, we can see the increasing severity of AD from week 1 to up to week 3. But finally, at week 6, there's a clear disappearance of AD in the neurorehabilitation group, as you can see here. For our second experiment, we would like to understand how specific neuronal populations are involved in the development of autonomic dysflexia. So we performed a chemogenetic experiment wherein we injected inhibitory designer receptors activated by designer drugs or DREDs into the hemodynamic hotspots or the lower thoracic segments in VGAT-CRE inhibitory neurons and VGLUT2 CRE expressing excitatory neurons. So first we injected the DREDS virus, the inhibitory DREDS virus, and we performed spinal cord injury in the same day. after 30 days, we performed our blood pressure assessments. As shown here in VGAT-CRE and VGLUT2-CRE mice, we show good expression of the DREADS virus. Following CNO or clozapine N-oxide injection, we show that inhibitory inhibition has no effect in this graph here, and excitatory inhibition has resulted in a reduction of autonomic dysflexia, as shown in this graph. To conclude, we show that long-term epidural stimulation completely abolished autonomic dysflexia. Second, the abolished autonomic dysflexia can be due to silencing these excitatory neurons within the hemodynamic hotspot. Also, for our future work, we would like to assess the clinical effects of long-term epidural stimulation in our recently approved DARPA-funded clinical trial. And we would also like to interrogate the circuit-level responses of long-term epidural stimulation that are associated with this abolishment of autonomic dysflexia. With that, I would like to thank our group for taking part in this project. Thank you.
Great talk. Thank you so much. So let's I don't see any questions in the chat, and I'm also kind of monitoring the participants if you have anything. So maybe I can just start off, not really knowing this field. So what is the hemodynamic hotspot? So is it something located only in those, what is it, T11 to 13? Is it a set of neurons, a specific set of neurons? Like what actually is that?
So we determined the hemodynamic hotspot using anatomical and functional experiments. So we would like to know which segments in the spinal cord are responsible for controlling blood pressure. So we injected a retrograde virus tracing from the splanchnic ganglia, and this traces up to the segments in the spinal cord that have shown the most abundant connections from the splanchnic ganglia. That's the first experiment. For the second experiment, we performed these functional stimulation experiments, wherein we stimulated each segment of the spinal cord and see which has the most response, increase in blood pressure in response to the stimulation. And then we performed these computational modeling, and we determined that these are the hotspots that control blood pressure.
Thank you.
Thank you. Thanks for that question.
Yeah, I don't know. I don't have a raise hand function. I don't know if anybody else does, if that's a problem. You could also write in the chat, I have a question, if you have a question. Oh, there you go, Justin Dennis. Just unmute and go, yeah.
Can you hear me now? Yeah, okay, perfect. Thank you very much for the nice talk. So I'm just sort of wondering how this epidural sort of stimulation works, I guess, on the molecular level to control your signals being sent out. So I think you touched upon it a little bit in the second part, but how is it actually working on the molecular level?
We have our hypothesis in terms of the mechanism of how the epidural stimulation could work in the circuit. So we have some experiments lined up wherein we will show that from our previously published work, we showed the neural substrates of how epidural stimulation work throughout the circuit. And we would like to see that if we target the same circuitry using epidural stimulation, and if this same circuitry is involved in the development of autonomic dysflexia, then we can target these hotspots every day with these neurorehabilitation, epidural stimulation every day, and we can basically reduce the hyperexcitability below the lesion site, if that makes sense.
Yeah, I think that makes sense.
Yeah.
Mm-hmm. Yeah. Okay, thank you.
Thank you.
So we have actually two more questions. We have one from Tristan. Do you want to ask that?
Hey, Elaine, great presentation. So some of your collaborators at UBC just published a paper suggesting that e-stim can also improve orthostatic hypotension responses. So kind of a flip side mechanism. Do you have any ideas of if these are working through similar neurocircuitry pathways or something different?
So just to clarify, acute epidural stimulation to reduce orthostatic hypotension. So the flip side of blood pressure problem.
Exactly.
Okay, so, okay, perfect. Thanks for that question. So from our previously published Nature paper, we showed that these targeted epidural stimulation in the T11, T12, T13, which are the hemodynamic hotspot region, when you induce orthostatic hypotension and you turn on the epidural stimulation, you can basically bring the pressure back up to its targeted baseline. And from our work, we did this in closed loop. So I'm not sure if that answers your question, but
more so is how you get these dual effects of being able to reduce pressure and increase pressure through the same, stimulator.
So basically, if you stimulate,
like
you
they're
have
kind
these
of almost
dual.
two distinct mechanisms, and so I'm wondering how one stimulator can do, both things by stimulating the same area.
That's true. So basically, with our epidural stimulation that we have shown, these are like controlled pressor responses. And so if we turn on the stimulation, we can basically, during orthostatic hypotension, we can basically raise the blood pressure back up. And I think with our future work, we will also show how we fix the orthostatic hypotension and also try to determine how we're going to fix the autonomic dysflexia in a more synergistic way. But that's a good question. Thank you.
Great. I think we're going to have to move on. Thanks very much. Elaine, there is a question in the chat from Dr. Fidak, so maybe you could just answer him in the chat. It's a question about large animal models, and congratulations on such a great talk, and thank you. That was fantastic. So we're going to move on to our second presenter, who's Karina Gomes. She's going to talk about the role of endothelial colony-forming cell-derived exosomes in cardiac repair post-myocardial infarction. So Karina, if you can share your screen, that would be fantastic.
Just a second. Okay. Can you see my screen? I'm not sure if...
No, we can't see it. I just allowed screen sharing that seemed to be deactivated, so just try it again.
Okay.
All right, go for it.
Can you see now? Perfectly. Okay, thank you so much, Sarah. So my name is Karina Gomes, and I'm going to talk about the role of endothelial colony forming cell-derived exosomes in cardiac repair post-myocardial infarction. Ischemic heart disease remains as the world's leading cause of death, as the ischemic injury leads to a chronic cardiac remodeling with a progressive decline in cardiac function. The current therapies for cardiac repair after MI are still of limited benefit, and in the last years, stem cell-based therapy has been proposed for cardiac regeneration, And one of the main mechanistic hypotheses for the stem cell-based therapy is the indirect stimulation of the reparative response through paracrine effects as exosomes. So among the most prominent stem cell candidates for the treatment of ischemic heart disease are the endothelial colony forming cells, or ECFCs. So as they can differentiate into functional endothelial cells, in our study, we have focused on the endogenous vascular reparative function of the cells and their exosomes. Briefly, we isolated the mononuclear cell fraction from the bone marrow of mice, which were then culturated for 21 days. So after that, we performed the ECFC and exosomes characterization, isolation and characterization, and some in vitro, ex vivo, and in vivo experiments to evaluate their angiogenic potential in our study. So in the ECFC characterization, flow cytometric analysis identified our ECFCs as CD34, 31, and 309 positive, and CD14 and 45 negative, which corroborate with the pure ECFCs. To evaluate the angiogenic effect of ECFCs, we used a murine model of Hindling ischemia. And as we can see in the red arrows, the ECFC treatments increased the blood perfusion in the ischemic Hindling. And interestingly, the blood perfusion in the ischemic the blood perfusion was decreased when we used inhibitor for exosome generation, showing the critical role of the exosomes for the angiogenic action of ECFCs. After the suggestion that the angiogenic effect of ECFCs can occur via exosomes, we decided to focus on the effects of ECFC exosomes. Exosomes are actively secreted as nanovesicles, and several studies have proposed that the beneficial effects of stem cells are mainly mediated by exosomes because of their ability to mirror the behavior of the original cells. In our study, we isolated exosomes from ECFC conditional media, and we performed a series of experiments to characterize our exosomes just to confirm the nanosize and the purity of our samples. We also performed some in vitro experiments to determine the role of ECFC exosomes in angiogenesis using the isolated mouse cardiac microvascular endothelial cells. So the endothelial cells were incubated with a green label exosomes. And as we can see, the most of the exosomes were taken up by the endothelial cells. In addition, we observed that the incubation with ECFC exosomes stimulated the endothelial cells proliferation. The migratory potential of ECFC exosomes on the endothelial cells was evaluated using in vitro wound healing assay, which indicated that the cell migration was stimulated by the exosomes treatment. In the tube formation assay, the ECFC exosomes treatment also increased the tube formation, and in the ex vivo aortic ring assay, the exosomes treatment increased the sprouting, which is an indicative of angiogenesis. So after that, we used a lead ligation model to evaluate the ECFC exosomes role in cardiac remodeling and repair after MI. In our study group, after the permanent ligation, the ECFC exosomes were injected in the peri-infarcted and infarcted areas. In a group of experiments, we used the intramyocardial injections of labeled ECFC exosomes after lead ligation to evaluate the ECFC exosomes biodistribution and retention. And as we can see, the whole body imaging showed retention of exosomes in the myocardium for up to 24 hours. 7 days after the lead ligation, acute MI resulted in increased mortality. However, the mice treated with ECFC exosomes showed markedly reduced mortality. The echocardiographic assessment of heart function showed decreased LV ejection fraction and fractional shortening, and the administration of ECFC exosomes after lead ligation prevented the cardiac dysfunction induced by MI. The histologic analysis of the myocardial tissue showed increased ventricular inflammatory cell infiltration, cardiac fibrosis, and severe loss of vascular density in MI group. However, the administration of ECFC exosomes preserved the myocardial tissue and reduced the inflammatory cell infiltration, the cardiac fibrosis, and improved the vascular density. To identify the microRNA cargo present in the ECFC exosomes, we used the RNA sequencing, and the top targets found in this analysis were the factor which inhibit HIF-1 alpha or FIH, which consequently reduce the angiogenic actions of HIF-1 alpha, and the phosphatase angiotensin homologue or PTEN, which inhibits the AKT pathway and thereby have an important role in cardiac remodeling. So to validate these potential targets, we evaluate the protein levels of HIF-1 alpha and PTEN in the hearts. And as we can see, the levels of HIF-1 alpha were decreased and the levels of PTEN were increased after MI, and the treatment with exosomes adjusts the levels of these proteins to increasing the levels of HIF-1 alpha and decreasing the levels of PTEN. We also evaluated the relative expression profile of angiogenesis-related protein, and as we can see, the treatment with exosomes decreased the level of angiogenic proteins and increased the level of proangiogenic proteins in heart 7 days post-MI. So our data showed that the ECFC-derived exosomes were taken up by endothelial cells, leading to their proliferation and migration, tube formation, and formation of new vessels. The administration of ECFC exosomes prevented the cardiac remodeling and heart failure induced by MI. We also identified the FIH and the PTEN as ECFC exosomes potential targets, and the ECFC exosomes changed the angiogenic profile in myocardial tissue after MI. I would like to thank you, my supervisor, and all the collaborators of this work, and I will be happy to answer any questions that you may have. Thank you.
Wonderful. That was perfectly timed and an excellent talk. So again, I don't see any hands for the chat yet. So I'll just ask, is there any role? I mean, I think the microRNA role is really exciting. Is there any role for proteins and growth factors in the exosomes, or is it mostly going to be just a microRNA mediated mechanism?
Yeah, so the content of the exosomes are formed by microRNAs, non-coding RNAs, proteins, lipids. For this first experiments, we are evaluating just a microRNA, but we are also planning to do some proteomic analysis to confirm the protein content of the exosomes derived from ECFC cells.
They're really interesting. Okay, Justin has a question.
Hi, Karina. Thank you very much for the talk. Really interesting data. So I had a question related to time frame. So you've looked at 7 days post-MI, but obviously function, we want this to be persistent. Have you guys looked out any further, a month out or beyond, to see whether this functional benefit is sustained and whether you still get this angiogenic sort of profile?
Yeah, thank you for your question, Justin. So for this first experiments, we are evaluating just the acute MI effects of the treatment, but it's something very interesting. I think probably we're gonna do that for the next projects related to these exosomes, because it's important to know the timeline of the treatment, how long this treatment should be done to keep these good effects in the cardiac remodeling. And as we have different phases in the cardiac remodeling with some compensatory phase and then this compensatory phase and then the heart failure, I think it's a very valid thing to try different timelines for the treatment and confirm if the treatment can be helpful in all of them, all this phase of cardiac remodeling.
Okay, and that's great. I just had one follow-up question, if that's okay. Okay. So when you're doing you're culturing up your progenitor cells, so are your progenitor cells actually maturing into a mature endothelial cell over those 21 days? So in other words, are the exosomes that you're seeing actually endothelial derived, or they're actually endothelial progenitor derived? And would you see a difference if you compared it to exosomes injected from, say, a HUVEC source or something like that, or a mouse, or I guess relevant endothelial cell line?
So for the culture of endothelial cells, we are working with the late outgrowth EPCs. So that is why we have to wait for these 21 days to collect the cells. And we are doing the confirmation of we are working with the ECFCs because we are checking all the surface markers which are specific for this cell line. So in that case, I believe that we can confirm that we are working with endothelial progenitor, endothelial forming colony cells. One of the problems with the clinical trials that we're working with endothelial progenitor cells until now is because they don't have the differentiation of the types of endothelial progenitor cells. So that is why we are trying to confirm the cell lineage that we are working, which are the true endothelial progenitor cells, before to continue with the exosomes isolation. So yes, we confirm that the cells are endothelial progenitor colony forming cells.
Okay, thank you.
Thank you.
All right, I think barring, I don't see any other questions. That was fabulous. Thank you so much. And we're probably ready to move on to the next section.